Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the gangrene. Gangrene is defined as the death and putrefaction of a macroscopic portion of tissues. It is usually affects the distal parts of the limb, the appendix, loop of small intestine, and sometimes organs like gallbladder, pancreas, or the testis. Sequester means the death of the group of cells through it is extended into the bone. A slough is a piece of dead soft tissue like skin, fascia or tendons. Types of gangrene depending upon the cause. Symptomatic or secondary gangrene. It occurs due to arterial obstruction complicating the existing disease like thrombosis of the artery, embolus from the heart in auricular fibrillation or after coronary thrombosis. In diabetes, arteritis with neuritis. In Buerger's disease, thromboangiitis. In Raynaud's disease, arterial shutdown and ergotism. The effect of intraarterial injections like thiopenton, noradrenaline and cytotoxic substances. Infective like boils, carbuncles, gas gangrene, gangrene of scrotum, phagodyna and cancrum oris, etc. Traumatic, direct as crush, pressure source and constriction groove on the strangulated bowel. Indirect, due to injury of vessels at some distance from the site of gangrene, as pressure on the popliteal artery by the lower end of fractured femur, or gangrenous contents of hernial sac. Physical, like burns, scars, frostbite, trench feet, chemicals, radiation, X-rays and electricity. Lastly, venous gangrene. Clinical features of gangrene. The gangrenous part lacks arterial pulsation, venous return, capillary response like return of the color, sensation, warmth and function. The color of the part changes from purple, mottled, pallid, dusky grey, dark brown, greenish black or black due to disintegration of hemoglobin and formation of iron sulfide. Clinical types: dry gangrene, moist gangrene or wet gangrene. Dry gangrene. It occurs when the tissues are desiccated by gradual slowing of blood supply and typically occurs as a result of atherosclerosis as in senile gangrene. The affected part becomes dry and wrinkled and greasy to touch. Moist gangrene. It occurs when the venous and arterial obstructions occur or when the artery is suddenly occluded as in ligature or embolus. Infection and putrefaction always follows. The affected part becomes swollen, discolored and epidermis may be raised in blebs. Sometimes crepitus may be detected on palpation due to infection by saprophytic gas-forming organisms. Moist gangrene is also manifest in conditions as acute appendicitis and strangulated bowel. Separation of gangrene. Separation by demarcation. A zone of demarcation between the viable and dying tissue appears first. On the surface, it is indicated by the band of hyperemia and Hyperesthesia. Suppression is achieved by development of a layer of granulation tissue which forms between the dead and living parts. These granulations extends into the dead tissue until those which have penetrated farthest are unable to derive adequate nourishment. Ulceration follows, and thus a final line of demarcation forms which separates the gangrenous mass from the healthy tissue. In dry gangrene, if the blood supply of the proximal part is adequate, the final line of demarcation appears in a matter of days and separation begins to take place neatly and with minimum infection, called separation by aseptic ulceration. If bone is involved, complete separation takes longer time and the stump tends to be conical as the bone has a better blood supply than its coverings. Moist gangrene. In moist gangrene, there is more infection and suppuration extends into the neighboring living tissues, thus causing the final line of demarcation to be higher than in dry gangrene, called separation by septic ulceration. That's why the dry gangrene must be kept as dry and aseptic as possible, and every effort should be made to convert moist gangrene to a dry type. Vague demarcation. Spread of gangrene. In case of gangrene by atherosclerosis and embolism, the line of final demarcation is very slow or may not develop. Unless the blood supply to the living tissue can be improved, the gangrene will slowly spread to the adjacent tissues or toes, or will suddenly appear as skip areas further up the limb. The signs of skipping should always be carefully looked for. Black patches suddenly appear perhaps on the other side of the foot, on the heel, on the dorsum of the foot, in front of the ankle and in calf. Infection is another cause of the spread of gangrene. May spread upwards beyond the line of separation along the lymphatic vessels or cellular tissue into the healthy parts, and extensive inflammation then results. Except in diabetic gangrene without atherosclerotic obstruction, these forms of spread do not respond to efforts to save the limb, and an above knee amputation is necessary to attempt local amputation in the phase of vague demarcation is to court failure, as gangrene reappears in the skin flaps. Treatment. General principles. The treatment depends upon the type of gangrene, the site of organ affected, and blood supply of adjacent structures. Life-saving excision or amputation. Life-saving excision or amputation is needed for emergencies as gangrenous appendix or loop of small intestine, gas gangrene, badly crushed limb, or spreading gangrene. A limb-saving attitude is needed in most cases of symptomatic gangrene affecting hands and feet. The surgeon is concerned with how much can be preserved or salvaged. With arterial diseases, so much depends upon there being a good blood supply to the limb above the gangrene, or whether a poor blood supply can be improved by such measures as direct arterial surgery, as embolectomy, grafting, or disobliteration, or interruption of the sympathetic nerve supply by a paravertebral block, or sympathectomy. A good or improved blood supply indicates conservative excision and amputation at a higher level through absolutely healthy tissue. General treatment. To improve the tissue oxygenation, correction of cardiac failure, arterial fibrillation, anemia, is required. Oxygen inhalation, especially hyperbaric oxygen in a compression chamber, seems more promising. A nutritious diet essential in all forms of gangrene and the control of diabetes if present are to be cared of. Pain, especially night pain, may be difficult to relieve. Non-addictive drugs like dihydrocodeine should be used. Local treatment. Care of the affected part includes keeping it absolutely dry. Surgical spirit exposure and the use of fan may assist in desiccation. Protection of local pressure areas as the skin of the heel, the malleoli. Otherwise, fresh patches of gangrene are likely to occur in these patches. A bed cradle or sorbo ring, foam PVC blocks or sheepskin called acrylic are useful preventive aids. Minor surgical toilet. Careful observation of a gangrenous spot will show whether the lifting of a crust or removal hard or desiccated skin will assist in demarcation or relief of pain. Amputation of the leg for gangrene. The amputation may be conservative, radical, and semi-conservative depending on the blood supply of the part of the limb. Conservative or compromise. There is no undue haste to remove a dry, painless gangrene toe where the final line of demarcation is satisfactory. A diabetic or frost-bitten part can be left to separate. An excision through the line of demarcation is performed when separation is proceeding well or if there is a localized infection. These wounds are left open to heal by granulation. If the bone and tendon are to be sectioned at a higher level, can be done through the cuff of skin and soft tissue. Special flaps are not fashioned in conservative amputation unless a portion of foot or forefoot is to be removed. A transmetatarsal amputation only possible when there is a viable long plantar flap extending along almost to the base of the toes. This is to be wrapped around the severed forefoot and sutured to the dorsal skin. A long dorsal flap cannot withstand the subsequent trauma from shoe. Radical repair of gangrene or definitive. When the conservative amputation is not possible due to failure of demarcation, spread of gangrene, failure of direct arterial salvage, surgery or sympathectomy, a mid-thigh amputation is indicated. It is essential to amputate high enough to ensure that the wound will heal soundly. The stump is 6 to 8 inches or 15 to 20 centimeters below the greater trochanter. Equal anterior and posterior flaps of skin and subcutaneous tissue and deep fascia are used. The muscles are divided at the level of bone section. Quadriceps divided with the knee flexed and hamstrings with the knee extended. Tourniquet is not used to control hemorrhage. The sciatic nerve is cut across and should not be ligated. The bleeding from the artery to the nerve is ligated. After sawing across the bone without stripping the periosteum, the leg is removed and full hemostasis is secured. Muscles may be grouped together by suturing around the stump. Before the skin flaps are carefully sutured edge to edge. The stump is drained through the wound or a separate incision and mild suction is applied via a sealed drainage bottle. Semi-conservative amputation or compromise. When the knee are frequently performed when conservative amputation of the foot will clearly be of no avail or failed, and where blood supply in the region of the knee is satisfactory by arteriogram. These amputations are either below knee, through knee, or supracondyle, or called strokes gritty. The blood supply must be adequate, and it is well for the surgeon to advise the patient that in the event of there being little bleeding in the flaps, the muscles, the radical above knee amputation will be necessary. Aftercare. The stump is immobilized between the sandbags for 48 hours. Sedation is given for pain. Thereafter, patient is encouraged by a program of promotion to a full and active participation in the community. This program entails exercises, sitting up in chair, getting up on crutches, and finally the measurement of fitting of and rehabilitation with an artificial limb. Early dressing and removal of drain requires sedation and an assistant to hold the limb gently but firmly between the two hands. When the wound of an above or below knee amputation has healed, the patient holds his limb himself while he is taught how to bandage the stump in such a way as to mold it into the cone shape necessary for fitting the prosthesis. Removal of the sutures on the 14th day depends upon the satisfactory healing, and if there is any doubt on this score, they should be left in for 3 or 4 weeks. Complications. Early complications. Reactionary hemorrhage requires operative hemostasis. Hematoma requires evacuation. Infection usually form a hematoma. An abscess, it is to be drained if present, and a sensitivity test is done and suitable drugs are given. Gas gangrene can occur in the mid-thigh stump by the organisms of contamination from the patient's feces. Wound dehiscence and gangrene of the flaps are due to ischemia, and a higher amputation may be necessary. For embolism, fat embolism is another uncommon sequelae occurring within first 2 days. Late complications. Pain may be due to unresolved infection, sinus osteitis, bone necrosis, and sequestrum formation. A bone spur scar adherent to the bone, amputation, neuroma from outgrowth of nerve fibers which attach to the skin, muscle or fibrous tissue, a phantom limb. Phantom pain. Patients frequently remark that they can feel amputated limb and is sometimes painful. The surgeon's attitude should be one of reassurance that this feeling will disappear. Should not tell about the phantom limb. Other late complications are ulceration of stump due to pressure on the pressure or ischemia. Rarely an ulcer is artifactal. Some patients are troubled by cold and discolored stump during winter, and sympathectomy may be required. That's all about the gangrene, and in the next video I will discuss about some other disease. Thank you.